So hello everyone, I would like to welcome you to this session of How Do I Do It? This session is on segmental buccal. So if you do not do any buccal, this session is definitely for you. We'll have lots and lots of discussion on the art of buccal, where, when, and how to do it. And we hear from our expert panels. So it's my pleasure. This is Ahmed Salam from Arkansas. It's my pleasure to introduce the panel. So our first speaker is Dr. Sharif Dapour from Zagazi, Sharqiya, Egypt. Dr. Sharif, welcome, and thank you so much for joining us.
Thank you very much.
And our next speaker is Dr. Tariq Hammam from England. Tariq, thank you so much for joining us today. I know it's late in England.
My pleasure, Ahmed. No, thank you. It's a Saturday night, so it's okay.
Thank you. And our next speaker is Dr. Hadi Zambarakshi from London, UK. Dr. Zambarakshi, thank you so much for joining us.
Ahmed, I'm very grateful for the invitation. That's very kind of you. Thank you very much for having me with you.
Thank you. I have a remark that I have to say that Dr. Zambarakshi was my boss, and he was actually the first teacher for scleral buccal. I remember very well my first case of scleral buccal that I did was him. So thank you so much, Hadi, for teaching me.
Well, the learning was two ways, I can assure you.
Thank you so much. And next is Dr. Ahmed Habib from Cairo, Egypt. Ahmed, welcome.
Welcome.
And last but not least is Dr. Mohammed Tawfiq from Sharqiya, Egypt. Mohammed, welcome, and thank you so much for joining us.
Thank you, Dr. Ahmed.
Okay, we'll start by just a question for everyone. Where does non-vitrectomy buccal fall in your practice? So what's the mix in your practice? I know you're going to speak about the indications, but I just want what part of your practice? Is it 10%, 20%, 40%? Let's start with Dr. Sharif Dapour. Dr. Sharif?
Now maybe 20 to 30% of primary RD.
Yes, we're talking about, actually, yes, you're right. That's a good point. We're talking about primary RD. And Tariq, what percentage of your practice?
So 10%.
10%. And Hadi?
Yeah, I'm the same as Tariq, 10%.
10%, okay.
Adults only, of course. Yeah.
So we have 10% from England. So what's happening in Egypt then, Ahmed?
So as you said, I'm a younger generation. And that's good for me. So I do it actually less than 10%. I do it for the younger age group. I don't do it much. My only indication is the patients less than 30 years with a home run buccal. When I'm sure that the buccal would be much more beneficial than the vitrectomy. If they are both equivalent in expected results, I would go definitely for vitrectomy.
Okay, so shall we say 5% or less?
I think less.
Okay, less than 5%. And Mohammed, what do you do?
1%.
Okay, 1% or one case?
1%.
Okay, all right. So we'll start this session by having presentations from our panelists. And then after that, lots and lots of discussion and questions. And please send us your questions as well, the audience. Tariq,
I just want to add something, and yes. I'm here to learn. So if you would excuse me for asking questions whenever I want, I'm taking this opportunity to do that.
Okay. So Ahmed, we don't agree with you. We're all here to learn. So from each other. So we're all in the same boat, and please do ask all the questions, of course. Thank you so much.
Thank you. Okay, let's start.
So should I share the screen, or is it?
Please. Yeah. Yeah. So I think share your screen again, Tariq, and we should.
Yeah, sure.
Maybe open the presentation first and share your screen. Okay, so here's your screen. Yeah.
So is it on now?
Yes, it's on. If you can just press hide there where it's down. Yes.
Yeah.
Yes, and I'm sorry, my mistake. Do it again. I do apologize.
Open again. Open again. Open again.
I'm sorry. We should have not pressed start. Yes. Okay. Yes, we can see it now.
Okay, thank you very much, Ahmed, for your invitation. I'm talking about my way of doing cryobuckle for primary retinal detachment repair. Right, so some geography to start with. I just want to share with you my journey in VR. I started my VR in Glasgow, and then I moved to Southampton after that. And now I'm practicing ophthalmology and VR somewhere in the middle here in Shrewsbury. So I started my fellowship in August 2003, and before I started, Tom Barry, who was the lead clinician for the VR service in Glasgow, published this paper or this debate about the best way of managing retinal detachment. He invited 3 expert groups to present the case for each technique. So either a segmental buckling without drainage, or primary vitrectomy, or pneumatic retinopexy. And that's his conclusion. So conclusion, you should reduce the drainage of the subretinal fluid, and the cryobuckle technique is the standard procedure for managing retinal detachment repair. Vitrectomy is unlikely to be the primary procedure for this pathology or this disease. And pneumatic retinopexy is only when you don't have an access to operating theater. So buckle was the standard procedure, and they would give me they give the fellow about 10 to 15 minutes to locate and mark the tear. If you mark it well, you carry on with the case. If you didn't mark it, they will take over. So you have to master the indentation with the indirect ophthalmoscope. And during that year, I did 85 buckles. It took me about 2 months to master the technique of vitrectomy. However, in cryobuckle, I wasn't happy till the last 3 months of my fellowship. So it took me about 9 months to master the cryobuckle technique. So it's not an easy procedure to do. And then after that, I moved to Southampton, and it was a surprise that, well, cryobuckle is an old procedure. We are only doing a vitrectomy as a standard procedure for managing these cases. And when I argue with them, they said, well, 40% of the retinal detachment are pseudophakic, so we shouldn't worry about the cataract at all. It's easy to teach the fellow 1 procedure only rather than 2 procedures. And cryobuckle, they claimed that it's not a fast procedure, and also it does hurt your back. So working in 2 units was 2 different views. That's what I think. So these are the cases where I feel that the buckle is a much safer and better option for the patient. Young age, and I've done cryobuckle on children with even a PVR. Once you close the tear, either with a buckle or when you drain the fluid, you will be able to flatten the retina. Dialysis, I feel that's a must. A vitrectomy is too much for these cases, and it's easy to start your career in buckle technique with doing this dialysis. You can see the dialysis with just a light on your head from outside without the need for the lens. And the trick in dialysis is when you are buckling, and I'll show you at the end my trick of dialysis of buckling these cases. In pathology, it's usually difficult to tamponade these tears, so it's easy to buckle them, especially if these patients are difficult to posture. And I feel 1 quadrant pathology, if you do a vitrectomy, that's too much for the patient, especially when you know that if you buckle that area, only that quadrant, this will be enough to flatten the retina. So you have to have the skills, I'm afraid, of the buckle technique. And I feel that if you are only doing a vitrectomy, it's like when you have a driving license only for automatic car. You can't drive a manual car. So how do I do the buckle technique? So when I started, I spent loads of time because they gave me the 10-15 minutes. I spent time trying to find the pathology in the back of the eye, meticulous preoperative examination. I would spend about 15-20 minutes trying to draw. And that's the Keel retina chart. I would accurately drawing all the retinal detachment break, associated landmark. So if as you can see here, I will take the blood vessel, so that dialysis extend from the lower temporal arcade. Sorry, I'll just go back. and my other landmark is the blood vessel, the retinal blood here. So this landmark will help you to locate the tear with the indirect ophthalmoscope. And then you have to be satisfied that the break that you found explain the topography of the retinal detachment. So you can't blame a tear on a flat retina for causing that retinal detachment. Okay, I'll just explain to you, or share with you my experience with this 23-year-old -6 myopic male. He was asymptomatic. He was referred from his optician because of right infratemporal retinal detachment, and he ignored any history of trauma. So my registrar examined him. I examined him quickly, and we couldn't find a tear. But that's one quadrant, 23-year-old. So I decided to do a cryobuckle. General or local, I prefer to do general, but I've done cases under local as long as the patient understands what I'm going to do. I usually do the conjunctival incision 1 to 2 millimeter. I leave about 1 to 2 millimeter because this heal better and better, especially if the patient wear contact lenses. And I usually close the conjunctiva at the end with 7.0 or 8.0 vicryl. And it's better when you deal with the muscle, you deal with them as a pediatric ophthalmologist, not as a VR. So if you look after them, they will minimize the risk of the bleeding. Okay, I use that cryo machine. It's usually good to work. And I don't use the reusable cryo probe. I use the disposable one. It's easy to manipulate, and nothing frustrating more than put the cryo in the right place and then ask for the cryo, and the cryo probe doesn't work. So if you are starting with, you start with the disposable one, and then you spend some time to locate the pathology. And then I found the tear in this patient at about 8 o'clock, and I mark it from outside. So you have to have a good assistant to mark the tear. And then with a teeth forceps, you put your teeth forceps in the middle of your mark and check again, because that's the most important step in the whole procedure. You want to make sure that the buckle is exactly at the middle of the tear, or covering the whole tear in the back of the eye. I use only 510. That's the buckle that I'm using. I use it radial and circumferential. It's easy. I don't like to use the full one. It's a little bit bulky. And I either put them at 2 millimeter or 3 millimeter. So I have, if it's a bolus detachment, I go for 3 millimeter. So I go for 8 millimeter. If it's a shallow detachment, I just put 1 millimeter on each side. And I try to avoid drainage the subretinal fluid. I only do loads of paracentesis to have a good indent. So, and then you have a look at that.
Sorry to interrupt. Can you go back to the picture? So here, so Dr. Hammam here is talking about the separation of the suture. It's a 5 millimeter buckle, just for the people who do not do buckle who are following us. 5 millimeter buckle. So then he will do the separation of the suture between 7 to 8. Separation. Yeah. Another way to think about it is to multiply times 1.5. So if it's 5 times 1.5, you end up 7.5 millimeter. So that's how you take your suture. Yeah.
Yeah. Okay. Thank you. Right. So if it's so that's you will have that if you don't spend the time in locating your tear. What you want to see at the end of your buckle is the bottom right here. So if you have insufficient buckle, you put it circumferential. So you want to change it for a bigger one. However, if you put circumferential, this will sort out this problem here. And as I said before, avoid drainage, because you might have that problem, right? And that's the this happens in about 10% of the cases. So 1 in 10, you will have that disaster. And if it extended to the submacular area, it will compromise the vision definitely. Right? I told you about the trick about that I use in dialysis. So I will just, so what you are seeing here, the dialysis is usually anteriorly. That's the insertion of one muscle. Oh, sorry. That's the insertion of the other muscle. So the surface area here in the back is quite big, so you can put your suture easily. However, in the front, you don't have enough space here. So you can put your suture, so it has to be double-ended. You pass one suture, right? So if you wanted 3 millimeter or 2 millimeter, you take a bite vertical, right here, and come anteriorly, right? And the other one the same way. And if it's tiny here, so if it's a short distance here, you can extend it outward. So you come out, you can put your needle here and come outward, sorry, and you can put it here, come outward. So the buckle, if you tighten your suture, you will have this 2 to 3 millimeter buckle at the end. So what I'm trying to say is, so buckling is still much better, safer option for certain patient with retinal detachment. It's not an easy technique, as I said before, so you have to spend some time till you are more comfortable with the technique. And VR surgeons are required to have both skills to manage retinal detachment cases. That's all. Thank you.
Tari, thank you so much. It's a great presentation. Tari, can you keep your last slide, the one with the buckle, and any questions?
Yes,
from
yes. I'm not following the suture here. Usually I take a suture if I wanted to put it horizontal. I take a suture at the line between the insertion of the muscles, and then another suture 7 or 8 millimeters away, one through and another, and then I close the suture over the buckle. Isn't this the way? I can't follow this.
You're right. Okay. So what I do here, usually the sclera here is very thin. And there is no enough. So you have a short bite. So if you go horizontal here, that's a short bite in a thin sclera. So sometimes you can't have a good grip of that. So instead of going horizontal, you go vertical. You go vertical. So you don't need to take. So that's the buckle here, right? So say 5 millimeter buckle, right? So you come in front of the buckle, put your needle, and come out 3 millimeter or 2 millimeter. Come outward. So double edge. That's one needle, and another one. You come here and come outward. So
it's one throw in the peripheral one. You get one throw horizontal, but in the one towards the cornea or the limbus, you take 2 and you tighten it, right?
Yes. So this one is as normal as we do. So that's from here out here. But this one you will need double-ended. So one needle out here and another needle from backward front.
Okay.
Tarek, can I ask you a question? So the suture that's further away from you, towards the posterior end of the break, this is a suture that's going to go parallel to the limbus, yeah? Now, when you come to the front, just at the muscle insertion here, it's fairly thick. So you can easily go back to front. So basically away towards the cornea, and then you go back on yourself, cornea towards away. That means you only need one needle. You're using 2 needles, aren't you?
So
you can do it with one needle, but just go the other way.
Yeah. You can go backwards, of course. Because here it's fairly safe to go in fairly deep because you're actually well away from retina, basically, at the muscle insertion.
But the sclera is very thin here. Sometimes if you go, you can see that the suture, she's wiring the sclera. It happened with me, and that's why
it cheese wires if you go. It shouldn't cheese wire if you're going perpendicular to the limbus. It will cheese wire if you go parallel to the limbus.
Yes.
You see what I mean?
Yeah. So I go perpendicular to the limbus.
Yes, correct. Yes. So that would avoid the cheese wiring.
Yeah.
I think, Hedy, the classic teaching, I don't know if it was you or Mr. Towler who taught me this, But the classic teaching is you do it this way, like Tariq, because the fibers here are circular.
Yeah, no, that's what we do. Yeah, I agree. Yeah.
That's actually the classic teaching in England.
Yeah.
You do it this way because the circular square fibers, so you pick it up.
Yeah, I quite agree. That's what we do. But we use only one needle. You go back to front to back. Yeah.
Yeah, Tara is working in a posh place. He got disposable cryos. He got 2 needles. He doesn't matter. He doesn't need to say.
I'm getting going.
So is this suture enough, or do you need another suture to put it in place?
It depends on how big is your.
Oh, okay.
I suppose it depends on how big is your buckle and how many breaks you have.
So I'm doing that only for dialysis. So for this
one suture, or you may need 2 or 3. You may need 2, right? Like the picture here, you drew it.
Yeah, so I do two here to cover just the dialysis here. So the problem with the dialysis is sometimes you put it posteriorly and not supporting the anterior edge of the dialysis. But if you do it that way, this will move the buckle forward and close the dialysis or support the dialysis anteriorly.
And you only use a sponge, the 510, not a tire.
No, yes, I don't use a tire. I use that for every single thing. And
Tariq, can I ask a question, Tariq?
Sure.
So if you were going to use a 277, for example, or a 276,
yes,
it's a bigger buckle, of course.
Yeah.
But then, if you're at least training someone else, it's probably the safest way of doing it because you can be perhaps a bit more assured that you will support that break. Of course, the dialysis is very anterior, so that doesn't matter too much because it's very anterior, the dialysis. But if you're talking about a U-tear or maybe a slightly more posterior round hole, then you might have to retroplace that buckle because it's not that wide, is it? You might have to go with it further back. Am I right? Let's say you don't have a dialysis, but you have a round hole detachment, and the holes are further posterior. So to support them, you might need to retroplace it. Does that make sense?
Yeah, I will put that buckle, the 510, radial.
Radial.
So, yeah.
And then you have to be very accurate with your placing because if you put a radial that's not perfect bang on, you will miss. You will basically it will leak.
Yeah. Well, yeah. If yes, that's why you need to spend time to locate properly the tear.
Right. Dr. Sharif, do you want to please get your presentation? And remember this point from Hadi about the radial and the localization. And I remember that as well. He used always to tell me that circumferential is more forgiving. And we will talk about that as well when we see other presentations. So remember, radial, you need to be really very professional.
Very good.
Very good, right.
You need to go train with Dr. Hammam if you want to put radials.
You need to go with Dr. Hammam. That's true. All right.
Okay.
Yes. If you play, we see your big screen, but we see we don't see your presentation as yet.
Now you see my presentation.
I'm sorry. I do apologize. Yes.
So what should I do? Should I stop screen? Is that right?
Yeah, I've done it. No, it's okay, Tariq.
Okay.
Yeah. Yes, we can see your screen now if you just want to run it. Just make it like full screen. Yes.
Is it full screen or?
No, not yet. Yes.
It's okay?
Yes. Beautiful.
Okay. Thank you, Dr. Ahmed, for your kind invitation. And I'm very glad to meet Dr. Hadi, Dr. Tariq, Dr. Ahmed, and Muhammad Tawfiq. And this presentation on about the scleral buckling or even segmental scleral buckling is still a valid technique. And all demographic studies that in 40 to 50% of eyes with primary retinal detachment has only one break. Another 20 to 30% has only 2 breaks. And this means that about 60 to 70% of eyes with primary ligamentogenous detachment are amenable to localized scleral buckling. The rationale for segmental scleral buckle is we buckle the retinal breaks and not the retinal detachment. Also, we treat the detachment of today, not of tomorrow. It offers single surgery in about 90% of eyes with no intraocular tamponade. Of course, after exclusion of eyes with posterior breaks or giant retinal tear or those with concomitant media opacity. Also, it is minimally invasive surgery. Prerequisites to successful segmental buckling, as Dr. Tariq mentioned, meticulous and careful examination with indirect ophthalmoscopy, scleral indentation, and by microscopy. Identification of all retinal breaks is the key to successful retinal attachment. Good instrumentation. This is a special fashioned localizer. I usually bend it in this way from Calesium curate. Also, well-trained assistants. As Dr. mentioned, this is link of rules which helped us to identify the primary break. It works usually only with fresh retinal detachment, but also careful search for another breaks is very important. My surgical techniques is periotomy, isolation of related recti, then localization of retinal breaks. Usually for small retinal breaks, I mark it with only one ink mark. However, in larger horseshoe tears or big tears, I use two marks, one in the middle of the mesopubic and one in the apex, or three marks, two marks for the horns and one for the apex. This is a localization mark. Cryowexian, usually we should never overfreeze, refreeze, or freeze the floor of the break. The buccal materials, buccal selection, as regards buccal material, I usually prefer soft silicone versus hard silicone, but only in dialysis I use tire 287. Buccal orientation, radial versus segmental circumferential, usually for small breaks or broad breaks, not long tears, I use circumferential buccal. For long horseshoe tears, I prefer radial buccal. The explant size or the buccal size, it is better to be twice the size of the break, and suture width is 1.5 the buccal size, and this is for round sponge, as here in this diagram. For circumferential buccal, I usually tend to place the tear on the anterior slope or summit of the buccal, because the circumferential buccal tends to migrate anteriorly with time, while the radial breaks, I prefer to be on the summit of the buccal. And the goal is to achieve a good tear-buccal relationship. To drain or not to drain, there is some indication, some situations where the drain is indicated. For example, where in stiff retina and PVR, inferior detachment in the patient with open angle glaucoma, I usually prefer to drain most of the cases. But if there is shallow detachment, no indication for drainage. The drainage, I usually use a modified cut down technique. This is a video of a patient has temporal retinal 50-year-old male with temporal retinal detachment and single break at about 8 o'clock, and the break was very close to the lateral rectus insertion. Here I use this instrument for marking, putting this mark, and then dry the sclera well before putting the ink mark on the break size. On the break side, sorry. Then after cryo, this is similar to that what Dr. Tariq mentioned. After making cryo, I double check that the cryo, which was for the break, is exactly on the ink mark. This is a double checking of the correct position or correct localization of the break. Then we make the sclera. So for such one single break, I usually take 2 sutures. And this break I put 4 millimeter rounded silicone sponge, and usually supports the posterior part of the bucket more than the anterior. So if you put 6 millimeter suture widths, we put 2 millimeter in front of the break and 4 millimeter behind the break. Then we put the scleral buckle, which is a temporary slip knot, and then we make a puncture rather than incision of the sclera. And deep until the black choroid become apparent. Then now we drain subretinal fluid and inject air intravitreally to restore intraocular pressure. But at that time, we don't inject much more air because I like to tighten the buccal in a relatively low, soft intraocular pressure. Then we trim the buccal and check for tear-buccal relationship and the patency of perfusion of central retinal artery. Chandelier segmental buccal. This makes benefit from the wide field intraoperative viewing system. Also, it limits or eliminates the need for entire ophthalmoscopy and thus decreasing the learning curve for scleral buccal surgery. This first we make localization in the same way. The first mark was not so accurate. This is the more accurate mark, and this we do cryo.
Dr. Sharif, we lost the sound.
Yes.
Okay.
Now?
Yeah.
But I think
Yeah.
the problem is with the video.
So until the video starts, can I ask a question?
Yes.
So do you put?
You hear me, but the video is not working. I just
I think you should close the presentation and open it once more. So you said that that you put the suture 2 millimeters behind the break in front and 4 millimeters behind.
4 behind. Yes, this is in circumferential part.
Why?
Because
usually I know that you suture at the you put the buccal at the midpoint of the sutures, right?
No, this is to put the tear buccal, the tear on the anterior slope of the buccal, because the circumferential buccal tend to time to migrate anteriorly.
Oh.
So if it migrated anteriorly, it will be on the summit of the buccal rather than on the posterior slope with posterior leakage later on.
Mm. So you put it slightly towards the posterior of the eye, so as if it slides, it would be in a favorable place.
At the summit, yes. Yes.
Okay.
Is it okay now or no?
We can hear you very well. Let me get your video again.
Now the video is in or no?
Just on the point.
You need to share. I'm not
the
sure.
video is clear now or no? You see the video?
Yes, we can see it. I'm sorry. Yes, go ahead.
Okay. This is the last video from the start. Now we make the cryopexy. This cryo is around the break, not because this is a little bit larger one.
So, Dr. Sharif, if I have a large break, you can cryo around the break 360, not on a single shot. Cryo.
Yes, for a large break, it's better not to cryo the floor of the break, but only 3 or 4 applications around the break.
Oh, you have a multiple application of cryo around the break, yes?
Yes. And this we take radial suture for radial buccal And the reciprocal buckle, we put, as you mentioned, on either side, equal distance from the break, as you see.
You take 2 throws on either side.
Two sutures, yes, two matrix sutures. And this is a 4 millimeter rounded silicone sponge. And we make drainage preferred to in the bed of the buckle, drainage side.
Do you cut the sponge at all to make it smaller, as in to make it flatter? Yeah, do you cut it in half? Do you know what I mean? Or do you always use it in full? Do you always use it in full?
No, I in this, because the break is a little bit big, I use in full. I don't cut it in half.
Yeah. Because do you find that the sponges give you very high indent, or
yes, this is the indentation. Now this is the indentation effect.
Yeah.
After drainage, the indentation buckle, tear buckle relationship is ideal here, and
so this
on the summit of the buckle.
This excellent. This buckle is a little bit posterior. So does it cause any field?
Yes, you see the marker or no? Yeah,
yes. I can see it. It is placed.
This is a break. We have the buckle must extend beyond the buckle. However, this buckle may
any visual problems?
Some astigmatism may be induced to diopters or something like
metamorphopsia?
No, metamorphopsia. This is Stihel's Chandelier segmental buckle with this. I tried it once with immunity system from Alcon, and this is similar to the other Chandelier buckle, but it's.
Dr. Salam, there are questions coming from the audience.
Yes.
It
I'll
might be
wait for Dr. Sharif to finish this audience question. Yes.
Okay. If you notice, Ahmed, this is an accidental drainage here. So you inject the air inside the eye and remove the site of perforation here to replace it more anterior one. And
yeah, that's very nice trick.
If it is posterior,
can't you inflate the eye with saline rather than air?
BSS,
not saline.
Yes.
Okay. Yes,
you can. With BSS,
but you need air. Now we check the
localization. I mean.
Now the optic nerve head was not perfused, so I removed some air underwater seal from the eye. And now you see the tear-buckle relationship here. The tear is perfectly on the buckle, and this is the drainage site. Now it is supported on the buckle as well. Actually, I think I hope the scleral buckling is will not be a dying surgery, but the limitation of scleral buckling now is limited patients because. Most of VR now prefer to do primary vitrectomy. Also, the buckling material now it is not easy to get it. Only
the sponge, we can't find the sponge right now.
Also, instrumentation when you have to purchase the cryo machine, it is very difficult. Also, corporates. This is cheap surgery, and it costs less than $100 US here. And I hope young colleagues continue to learn scleral buckling. Thank you very much.
Dr. Sharif, thank you so much. I have one comment, and then we'll take questions, and then I'll hand to Ahmed and Muhammad if they have any other questions. Let's get us all here. I just want to comment really, it's a beautiful presentation, beautiful video. And this video of the radial buckle, I cannot really find the words to describe how beautiful it is. It's a real art. It is beautiful. It's a really beautiful video. How you got this big tear on the buckle, it's really beautiful. So thank you so much. Teslam Eidek, yani. Beautiful.
The tip is in the meticulous localization, and usually, as Dr. Tariq mentioned, I use the cryo. After just making cryo, the assistant retracts the muscle, so I confirm that the cryo application on the mark we put before.
No, it's just beautiful buccal team relationship. زي ما بيقولوا في ميلودي يعني أستاذ فعلا. It's really beautiful. It's really. Then let's go for questions. So we have from Dr. Nabil. Dr. Nabil is not in Egypt, so he's not following the football match. And he was saying, what's the advantage of modified cut-down drainage technique? So we have two drainage technique. One is the prang, where you just pierce, and one is the cut-down. And Dr. Sharif showed us the cut-down. So Dr. Sharif, why do you like the cut-down?
The cut-down over the direct needle perforation.
Yes, like instead of this, what we call the prang, like just with the needle.
Yes, many times this direct perforation of the needle. Usually, subretinal fluid comes out and causes imbibing or swelling of the scleral fibers, and this can cause a choroidectomy or the choroidal opening. But when you cut down, or this modified cut down, I learned it from Professor Siam. It is not a scleral incision, it is rather than scratching the scleral, then you deepen it by the blade number 11 till you see the choroid. So you directly perforate the choroid. So this is makes drainage of subretinal fluid more complete.
Right. Okay, any comments from the panel on cut down? I have one final comment on this, but any comments from the Tariq?
So can I ask Dr. Sharif?
Yes.
So they wrote down, so I did the Brang technique for the, if I have to, and my incidence is 10%. So with your modified technique, do you still have 1 in 10 or less than that?
I didn't get the question.
The
hemorrhage?
subretinal hemorrhage. So subretinal hemorrhage is 10%, and that's my own experience as well. So 1 in 10 I have of this complication. In your hand, do you still have the one?
No, less than
10%.
Actually, I didn't most of the cases, and usually, alhamdulillah, less than 5%. The problem from bleeding comes from one thing. It is hypotony. So you should never the intraocular pressure become low at any time. If you have drainage, there is a very, very important invisible step here. Is the left hand you are tracting on the recti muscles. So when the subretinal fluid is draining, you are, as long as subretinal fluid is exiting the eye, you make more stretch on the eyes. You don't allow the IOP to come down. And after you make drainage, you inject air inside the eye. If you notice the hemorrhage at any time with more air, so that if you have bleeding, you have limited bleeding, and position the eye so that the blood comes, so the eye towards the nasal side from the macula.
Right, Hadi, do you have anything on the drainage? Are you going to show anything on the drainage, or?
I mean, I was going to show a single picture of a needle drain technique, which, as you know, Abed, this is how I do it.
Yeah.
I really very, very much agree with Dr. DeBoer. The eye goes soft, that's when the bleeding can happen. So you need to have the eye, you don't want the eye to go soft. So the last thing you want is a prune. The eye to look like a prune, basically. And one of my top tips, which I will just mention a bit later, is before I even start, I always have on my surgical trolley 1 2-minute syringe with air and 1 2 syringe with BSS. You may remember we talked about this before.
Yeah.
So in case the eye goes soft, I don't have to spend 5 minutes getting someone to give me a syringe with air or with BSS. It's just ready to reform the eye straight away, so the eye does not go soft, because that's really one of the biggest problems that can happen.
So when do you use air and when do you use the
Well,
BSS?
I can use either. I don't mind. But if you put air, your view might become a bit more obscure. So
Yes,
if you
that's why I was
air, I mean, the standard old initial technique was this for the ACE procedure where you do drain air, cryo, drain and air. But then, of course, that makes your view a bit more difficult. So I usually reform with BSS as a rule, not air. But if I'm doing it at the end, then I might use air.
What's the difference between saline and BSS if you need to reform the group?
BSS is more physiological than saline.
Mm-hmm. This is the only.
Usually use ringer.
It's balanced salt solution, so it's what you use as part of your phaco. So it has a few more nutrients and that are a bit more physiological for the inside of the eye.
How about the ringer?
I think BSS and BSS Plus is the thing to use basically. I'm not sure about the ringer, but I suspect that there's this may be okay as well. I'm not sure.
We always use it.
Yeah. I think, Ahmed, if it's not available, people use ringer. We used ringer.
Yeah, I think you're right. Yeah.
Solution is the posh thing, and BSS Plus is the the more posh thing.
So is the
so I just want a summary here on the drainage, so you can do the prang or the cut down. I think what Dr. Sharif is doing is a modified cut down because he doesn't do a long incision and he does not treat the cryo with the diathermy. So if you take the prang versus the really cut down, the real cut down is bigger. You treat the cryo with diathermy, so your risk of bleeding is less. But because the incision is bigger, you have a risk of incarceration.
Yes.
So to just note, with the prang or the modified cut down that Dr. Sharif showed, your risk of incarceration is very, very small, if any, because there's a small opening, right? But then because you have not treated the cryo, your risk of bleeding is higher. So that's why you have to be on high pressure. That's why you have to hold on to the muscle sutures or have lots and lots of cotton buds everywhere and get the assistant to press on them. And that was my job.
For some time.
For some time.
The technique for the needle drain is really very simple. You need to you get a needle that has not been used. You put it on a forceps that clicks. So and you only want about 1.5 millimeters of the needle tip showing. So you prang and out, and you're only going to go that far. You can't go any deeper than this. And the idea, of course, is risk of incarceration.
Yeah, it just
what's the length of the needle?
The tip that's showing, that's going to prang 1.5 millimeters or maybe 2 at the most, depending on how deep is your detachment, how bullet is your detachment. Yeah.
So you can get
before the cryo.
Sometimes
before the cryo, right?
If you can do it either, but personally, if I've got a very
drain after cryo.
Yeah, drain cryo first.
All right, so Ahmed, you get 1 millimeter on the needle holder. You can measure it, or 1.5 to 2 millimeter. You can measure it on the caliper, like when you're starting, to just know what's 1.5 millimeter. It's just a little bit controlled if you're starting. When you're experienced as Dr. Dabour, you can just eyeball it. But just note the difference, in the technique and also the risk of complications between a real cut down with you treating the cryo versus a prang. So the prang, the pressure should be high. If you do a cut down and a big cut down and you're treating the choroid, the pressure should be normal. It shouldn't be high pressure because you can get retinal incarceration.
Yes. I use. Actually, I use some technique similar to what Dr. Hadi mentioned, but with the needle of 10-0.
Yeah.
In cases of non-drainage, after making when suture and tension is high, I hold the needle in the same way with the needle holder, exposing only 1 or 1.5 millimeter, and punctures the sclera full thickness through it. And this make a release of subretinal fluid, not too much, but some sort of like a paracentesis to help suturing the other suture with adequate buccal height.
So with your cut down, Dr. Dabour, you cut the sclera, and when you choroid, you stop, and then you puncture with the needle with the blade.
Yes. I punctured the needle at 20 gauge, 28 gauge.
With 20 gauge.
Yes, 28.
28.
Okay.
Yes,
And
not
the
20.
reason you cut down here is just to see, like, you have a bigger opening, right? So why don't you just puncture with a 28?
As I mentioned before to Dr. Nabil, because sclera fibers absorb subretinal fluid and get swollen
Good point.
and close the choroid.
Okay, so and the other point really is where to drain. So you want to drain at the maximum height, preferably in the bed of the buccal, like Dr. Sharif showed us, right? So that if you happen to perforate, it's covered. But then you need also to think of the vortex veins. And
Yes.
the best way to think of the vortex vein is to imagine a clock face, and then in between the 6, 12, 3, and 9, these are where the vortex vein are at the equator. So they will be like
Yes.
on the oblique quadrants, right? So that's why they say the best way to drain is under an inferior rectus, or at the borders of a horizontal rectus or under a vertical rectus. You just want to get away of these vortex veins, and you can eyeball
Yes.
them as well. So that's something to consider. The highest, the bed of the buccal, and also try to get away from the vortex vein. Dr. Sharif, do you have any tip on that?
Yes. Of course, you have to drain in a place where the retina is detached.
Right.
First. Otherwise, if you have total detachment, for example, the best side to drain is above and below the horizontal cry.
Right.
Also, it is better to position the drainage site under the buccal, in the buccal bed, in case of even complication from the drainage site. If you have nasal and temporal, it is better to be nasal rather than temporal. Also, lower better than the upper. Usually away from the vortex vein, away from the cryo sites, preferred cryo site, because the choroid is congested usually at the side. Away from the long posterior ciliary arteries. This is a preferred drain site.
I think these are very, very nice tips to avoid bleeding, and also to avoid, if the bleeding happens, goes to the macula. So nasal and inferior as well. Beautiful. And I think one question here, probably the meaning of the question is cryo before or after the drainage. I mean, the ideal thing maybe drainage before the cryo, because then the eye is not congested. But if you're starting, it might be difficult to cryo when the eye is soft and the view is not very good, especially if you put air. But again, the thought behind it is that you drain before the cryo is congested. But it's a little bit tricky when you're starting. So Dr. Sharif, do you drain before the cryo or after the cryo?
No. I drain before cryo. I cryo before drain.
You cryo before the Tariq, what do you do?
Sorry?
No, I'm asking Tariq. Sorry, Tariq, the mute.
I try to avoid drainage, but if I have to, it has to be after
cryo. And Hedy, what do you do?
I would drain before, because I tend to drain before, but I have to say it depends on which detachment you choose to buckle. That's really the key thing at the beginning, because there are detachments that are a bit more complicated, and then so you can get away with draining before cryo quite easily if it's not a very complex detachment. If you drain before and you've got a very bullet detachment, and the eye becomes very soft, you better be careful and better reform the eye quickly.
Yeah.
So the way I understand it is that you drain to approximate the break so as to localize it better. So it's logical to drain before than drain after the cryo.
What I do is, I as just like Tariq said earlier, it's absolutely critical that you examine the eye really carefully before you start, as in clinic. So when I'm actually operating, I already know exactly where every break is and what I want to do. And then for me, it becomes easier to drain and then cryo, because I actually know where these breaks are going to be.
But sometimes if the retina is so high and it becomes lower, the break site shifts.
So I place my sutures first of all into the sclera, because you can't suture if it's a soft eye. I then drain. I cryo, and then I place my buckle.
Hedy, can you show us your presentation as well, and we can touch on that as well. So if you want to upload.
So let's see.
So a question to everyone as Hedy's uploading: do you if you do buckle, do you encircle with 41? Dr. Sharif, do you encircle, or I see you like segmental buckle like Tariq, right?
No, I usually actually I don't do encirclement unless in conjunction with vitrectomy. Sometimes a few cases, and also in children, but not with 41. I may use 506 sponge, oval sponge. This is very similar to what Dr. Tariq said, like 510, 506, 506.
Right. Hedy, I don't see your presentation.
I'm sorry?
Here, I've added it here. This is your yeah, if you can run your presentation.
So I need to just, what do I have to do here? Hi.
Yeah, it's beautiful, Tariq, that you use 5mm and Dr. Sharif used 4mm. It's all about the localization and the separation of the sutures.
No, why can I not see my presentation, Tariq?
Yes.
You got me there?
Yes, just if you can run it. Yes, we can see you beautifully.
Okay.
Thank you,
So, so this is sort of my first slide. You know, when do I do a buckle? I tend to buckle inferior retinal detachments in young myopic eyes. These tend to have round holes, detachments associated with retinal dialysis, and small detachments in phakic eyes in patients around age 50 and 60. If you want to avoid the development of an early cataract, these are, you know, generally speaking, the sort of detachments that I would tend to buckle. I usually do not. Well, in fact, at the moment, I probably never encircle an eye, and I certainly never use a broad buckle to encircle. That's definitely something I don't use anymore at all. So I thought I can just move on to show a few cases of mine, and maybe for the panel to discuss. This case is a 50-year-old male who was referred by his optometrist with an abnormal retina in his right eye, asymptomatic, left eye normal, vision 20/40 right eye, 20/20 left eye. So this is the right eye. So his 20/40, I think 20/40 vision, right eye. He's got fluid superiorly above the disc. You can see some demarcation lines over here. And you can see here a very thick demarcation line as well. Asymptomatic. I thought Dr. DeBoer, he's a keen buckler. Maybe he can tell us what he would do with the patient, or, you know, operate, not operate, buckle versus vitrectomy.
Dr. Sharif, what would you do?
This patient, the question is buckle versus vitrectomy or observation also?
Do you operate? Do you not operate? Good vision, long-standing, asymptomatic. You can see he's got fluid superiorly, and a very thick demarcation.
This is superior, not inferior. Yeah?
Superior. That's right. Yeah, superior.
And you have a visible break or no?
Yes, round breaks superiorly. Yes.
Yes, I will do buckle, not vitrectomy.
I mean, I quite agree. Tariq, would you do the same, or what would you operate at all? Would you leave him?
No, I will leave him. I mean, he's totally asymptomatic. I can see a very nice scar surrounding the retinal detachment, right? So I may destabilize a very stable condition.
So Tariq, this is really important. That line, that very thick line, does that guarantee the fluid will never break through it? Do you think?
Well, if it breaks through, I will do. He will start to be symptomatic. In which case, I will intervene. I mean, you can apply another 2 rows of laser if you are in doubt. But that's a very nice scar.
Yeah. Okay.
I can agree with Dr. Tariq if it is lower, but upper, I think I can.
Ahmed, did you operate?
Laser is good option also.
Hedy, I was hoping that you don't ask me, because I've done either. I tell the patient, and sometimes it's easier when the patient say, no, I wanted buccal, or I want surgery. And sometimes they say, no, I don't want surgery. I think more as well, young patients, I may treat, old patients, I may watch, but it's a difficult one.
Well, I'm going to move on quickly to my next case. A 53-year-old male, referred by his optometrist, abnormal left eye, right eye normal, 20/20 each eye. This guy has been in fights so many times. He's had trauma to the face, right eye normal. Now it's the opposite. The stuff is inferior. Thick demarcation line again. It's inferior, okay? So are we going to do something now, or are we going to leave him as well?
Here I will observe and lower detachment.
Yeah, I mean, I quite agree. I mean, that would be my thinking. Is if it's inferior, I might just leave him and observe. The superior one, I might sort of be more keen to operate with the previous patient that had the superior detachments.
So that's a good point, really.
So it's just sort of interesting, the location of detachment in terms of surgery versus no surgery. But I think both patients are, in my hands at least, buccal patients. Would anyone consider a vitrectomy on this patient?
No, I don't think so.
Dr. Tawfiq, we have radio silence from you.
Would you consider a vitrectomy on a patient like this if you had to operate?
According to the age, if the patient is is older, I will do vitrectomy.
He is 53.
Yes, vitrectomy for sure.
So he doesn't have a PVD. So how are you going to manage this case if he doesn't have a PVD?
Do PVD.
What's the problem if you don't have a PVD?
It's not a problem. So you just did.
Oh, actually, with no PVD, scleral buccal will be much easier than vitrectomy.
I mean, but in my hands, the vitreous makes a big difference to me. If there is no PVD, and a patient under the age of 50 or thereabouts, I would probably be talking buccal as well. In fact, I would almost certainly be talking buccal. If there is a PVD, then I would prefer to see a superior detachment if I was going to, do a vitrectomy. If it's inferior, buccal is an option, I think, really as well.
Usually, we see these cases for younger patients who are asking for LASIK, and they don't have any idea that so I either would observe or do an encircling buccal with an inferior.
Why would you encircle the patient? I mean,
Ahmed is out.
Ahmed chose the best time to drop off.
Okay. So
Yes.
the question to the panel is, why would you consider encircling? And if you do, why would you encircle? His superior retina is absolutely fine. He's just got an inferior detachment.
I like what Dr. Sharif said. I really like it that he's treating the detachment of today, not of tomorrow.
Okay. So,
Yes, I
really like that.
I prefer to do circumferential buccal to the primary break only, not encirclement.
Yeah, I agree.
Yeah, I really like this. I really like it like synced in me. I really like it. It's yes. We treat the detachment of today, not for
Yes.
Yeah. Shall I move on to the next case?
And then we'll get Dr. Habib when he comes back.
So this is a 58-year-old male, myopic, both eyes about -6 each eye, previous detachment left eye, asymptomatic right eye.
We are not sharing the screen.
Can you see my screen?
Sorry, yes, we can.
Dr. Salam, show us the
now.
screen, please.
I'm sorry?
Yes, we have.
Okay.
Vision
Yes.
20/30 right eye, 20/20 left eye. So this is the left eye that had a previous detachment, okay? He's had you can see he's got a big scar in Philly. He's a myopic, you can see from the disc. And that's his right eye. So the right eye's got basically a localized detachment here with what looks like a big cyst under the retina as well. So, I mean, you can probably see what I've done in this case, but I'm not sure how would the panel manage this patient? Dr. Tarek, what would you?
So is he asymptomatic Hadi or just asymptomatic?
He's asymptomatic. He's had a detachment in the other eye, and
Yes.
now that's his right eye.
No, I will just surround that area with laser. I mean, I can see that it's a nice laser here. It's a faint scar. I will just top up the laser surrounding that detachment.
I mean, that's exactly what I've done in this case. I put some laser around this detachment.
Dr. Sharif, what would you do?
Yeah, I do agree with Dr. Tarek and Dr. Hadi also.
I would do the same as well. In my mind, I mean, it's a difficult to buckle this one. It's a very big tear.
Yeah.
And he probably, I mean, from the configuration of the tear, he does not have PVD. And, you know, this is an eye seeing well. So I think the least to do really here would be doing laser. So that's what I would do as well.
That's a big cyst, I think.
Where's the tear, Hadi?
You know, I'm not sure I could even see a definite break. He had a big cyst over here under the retina.
I feel that
So it's a chronic.
would be to
It's a chronic.
It is chronic.
Localization.
I agree. It is chronic, yes. I mean, do these cysts alter what you do? Dr. Sharif, does it change what you do if you see a big cyst under the retina?
No, this is a big cyst. That means that this detachment is lasting more than 1 year. This is means the condition of the retina is stable for a long time. So I think only laser photocoagulation is a wise decision.
Okay, I'm going to move on to my last case. 28-year-old male, blunt trauma, right eye, football injury. Left eye normal, vision 2100, right eye 20/20, left eye. That's the right eye. He's got a detachment. His macula's off. And that's the peripheral problem. You can all see a big dialysis over here. And in my hands, this is a case for a buckle. Does the panel agree, or would the panel do anything different?
Yeah.
So I will do buckle to start with.
Yeah.
So I will do a buckle and see what will happen. If the retina, I can see some subretinal fibrosis.
Yeah.
But I will do buckle. Maybe I will drain in this case and put air. So is that upper temporal dialysis?
Yes.
It's upper temporal. So I will put air, and if it didn't work, I will go for vitrectomy. But hopefully the dialysis would be my first option.
Yeah.
Dr. Tarek, why you didn't start with Buckvit? Why you didn't start with Buckvit?
With the buccal vitrectomy.
Yeah.
So I will do two stages. It may work only with the buccal. So if you buckle that dialysis,
in your hands, if this case can be done only with buckle?
yes.
Yes, definitely. I mean,
What's
I think dialysis do really well with buckles. Dialysis do very well with buckles, I think. I mean, they're the greatest to do with buckles because it's very anterior. I think I tend to use a 277 a hard silicone segmental.
Yes.
The advantage of this is, you've got much more less room for error because it's called break to aura occlusion. So basically, you're going from the break all the way to the aura, and therefore your margin of you've got less room to go wrong, so to speak, and you can easily support a very anterior break in that technique.
Yes, this is an excellent case for buckle. As you like, to me, I will use hard tire also 287 actually biconvex.
Yeah.
And the aim is to also I will drain to have low broad buckle to support this area. And my observation actually for such cases, the subretinal fibrosis rarely interferes with retinal reattachment. And in literature, they used to say that retinal dialysis is a contraindication for parasplanal vitrectomy because they convert it into giant retinal tear.
I quite agree, actually. I mean, I think I've certainly learned the hard way from operating on a young patient with a detachment where I thought there was a PVD, and I did a vitrectomy, and in fact there was no PVD, and you can really struggle inducing a PVD in a young patient, and then you end up with all sorts of other problems because if you don't separate that posterior hyaloid, it's going to be very difficult to reattach the retina and to get the fluid to drain completely.
It's really a great case for discussion, and I would do the same as well, like Tara and like all of you. I will try buckle, and sometimes really it works so well, and I will drain as well. It's a chronic detachment, and I will drain.
Yeah.
That's that's what we're after.
Ahmed, I'm going to give you my top tips for buckle. I think the key thing for me with doing a buckle is, I mean, I quite agree with the panel. Is we do less buckles in general, and therefore we in general have become not as good. And so there are some excellent bucklers, and I know that some of you, like Dr. Sharif, who do a lot of buckles, will be very, very good at them and very elegant at them. So if you choose the right case, then life becomes easier. We mentioned before, as Tarek mentioned, preoperatively, a very carefully retinal exam is very important with indentation to identify all the breaks. I mentioned that as well. Always have a 1 or 2 ml syringe with air or BSS on the trolley. So if you need to reform the eye after draining, it's there for you. The buckle must support the posterior margin of the break. That's really important. Draining is not always necessary. I personally avoid inserting bands, and I never encircle with a large hard tire. I never ever do anymore. I've seen too many complications from inserting with a large tire. I think if I'm doing a vitrectomy in my hands, I never put a buckle anymore. I have not done a buckle vitrectomy for, as far as for many years now. If there is residual fluid inferiorly after surgery and all the breaks are supported, be patient and wait. I will reabsorb. And I never buckle a diabetic detachment. So these are my top tips for buckles.
Dr. Hadi.
Yes.
Point of no need for buckle if you are going to do BBV.
Yes.
You mean that in specific lower retinectomy can be replaced by a buckle?
Well, yes, but not at first procedure, of course. So the answer is basically, I'll tell you what. Let's say I've got some PVR and I've got it, and I reattach the retina, but I'm not entirely sure it's fully attached. I would rather leave the eye with oil, go back in, do a retinectomy later on, then put a buckle as well as a vitrectomy, and risk the problems of buckling the eye. So so yes, I would be happier with the retinectomy than putting an NV buckle in the PVR case. Yeah.
Dr. Salam, you believe that lower retinectomy is maybe replacing the lower buckle?
So I'll tell you what I do. I mean, I think it's a little bit away from the primary buckle, but it might be a good point for discussion. Mohammed, do you mind if we leave that point to discuss with your case? And so the question would be like PVR and the role of PVR in the buckle. So I think let's finish this with your case as well.
Yeah.
Are you good with this? Because that's a good point, really.
Perfect.
Ahmed, do you have any question to Hadi?
Yes, I have. Yes, actually, you mentioned that you don't do encirclement at all. Why is that?
I've seen a few complications from encirclement. The retina is attached. We're all very happy, but they've got diplopia. They're not, the strabismus guys can't sort it out properly. I've seen buckles, thin out the sclera so much the patient comes back with busy scleral erosions, sclera falling apart. So having one case like this is enough to put you off encircling an eye. And these really big tires, they really sort of squeeze the eye so much. They're the easiest to put on, of course, because you just put them around and suture them, and that's it. But remember, you tend to suture these if you, let's say you do it at the time of vitrectomy, the eye has air in it, so it's very easy to overdo it, to make it too tight. So these encircling related complications can be, are not very forgiving, really, and I really don't see the need for them.
Okay, so another question for the panel. If you had a posterior break, let's say in the mid periphery, can you do buccal for it? So what's the vitrectomy session for the posterior break?
So with the posterior break, can you buckle it or not? So I will just go and have a look with my indent. Do I feel that I can buckle it with a radial buckle? If that's the case, I will go for a buckle, especially if they have other reasons. So if he's quite young and only localized pathology, I will go for a buckle. But if it's posterior that I won't be able to manage, I will go for a vitrectomy.
I will do like Tariq, but I'm actually.
See, I'm not sure I can decide if I can or cannot do. So what do you do?
I will set it up. I will
just indent.
So I will try in the clinic, but if I'm not sure, I will take the patient to theater. I'll tell them I will start by having, and that's when I was working with Tom Barry, I wanted to do a vitrectomy, and I would say that's a posterior break. He would say, well, let me to have a look first to see if I can buckle it or not. So he will sling the two muscles, the horizontal, and see where is the tear. If it's really posterior, okay, get me the vitrectomy. If
Tariq,
it's anterior,
Tariq, can I ask, are you talking about the detachment with a PVD and break, or are you talking about a non-PVD detachment?
I think both. I mean, as long as I can't deal with the tear, if I can't buckle the tear, I have to do something.
Yes.
So if it's a non-PVD, pneumatic is not an option. So I will go vitrectomy, and I will use a PVD, and then I'll deal with it. I mean, if I created iatrogenic break, I will deal with it, secondary to induction of a PVD.
So if you're going to do a vitrectomy, would you buckle as well?
No, it's either one way or another.
Okay.
Dr. Sharif, can I ask something to again, that goes with Ahmed's question? The case that you did the radial buckle on, what was the age of the patient? Just about.
The radial buckle?
Yeah.
The radial buckle? It was about 52, 53.
And I think this is a patient who had PVD as well, right? So it's more of a horseshoe.
Yes, actually, yes. But actually, absence of PVD, of course, favors the scleral buckling. But absence of PVD does not contraindicate scleral buckling.
Yeah, no, I'm with you totally. So I think, Ahmed, to answer your question, I think in a case like what Dr. Sharif did, I'd probably do a vitrectomy on it. But because non-vitrectomy is better, because I think in my hands, I cannot get it as nice and really as elegant as he did. But I really should try. And I think, radial buckle is really an art. And I think what Tariq is saying is a nice thing to take home, it's like if you can reach it nicely with the indentation in the clinic, then actually you can buckle it. But this is a difficult case to start with. I think this is one of the most difficult cases you would start with.
I mean, traditionally, the easiest ones to do are the dialysis are the easiest ones to do for the buckle at the beginning.
Yeah, this is a difficult one. I will not start with that case.
Actually, I have a comment.
Please.
I have four pictures.
For the question of Dr. Ahmed Habib, it's a posterior break. As Dr. Tariq mentioned, actually, we may not need to open the conjunctiva before. If the posterior break or what you see is a posterior break is temporal or upper temporal, you can make indentation before opening the conjunctiva. In the temporal fornix, you can reach as far as about 40 millimeters from the limbus. So with indentation, you can, if the break is in this quadrant, upper or superior, upper or temporal, you can judge if the break is really posterior. You cannot reach it with a buckle, or you can reach it with a buckle for suturing.
But Sharif,
That is,
Sharif, you agree that this is a difficult case, right? Not for the starters, correct? Not for
Sorry?
someone who's starting. This is a difficult case, not for someone who's starting, right? The one you showed, you agree that it's a difficult case, not for someone who's starting buckles.
No, I don't hear you, Dr. Ahmed Salam.
I was saying it's a difficult case, the one you did. This is like not for someone who's starting, right?
Yes.
Yeah, it's definitely a difficult case. Ahmed, you got cases, right? Shall I show? I'll show 2 cases quickly, and then
Yes.
after that you can show your case for discussion, and then we end up with Muhammad's cases.
Okay.
Is that okay? All right. So
Okay.
I got
So I
here.
reset my connection because it's shot.
Okay. So I use like Tariq 510, which is very nice, and I got that from Tariq. I always call him about buckles, and then I know he was using 510, and I really love 510, and that's what I mainly use, which is half the 5 millimeter. I just want to show you 2 cases again for discussion. This is a patient here with a non-PVD detachment, and this is really very important for me, is PVD and non-PVD. Young patient, rounded hole, it's mostly non-PVD detachment, right? So that's for me, and a chronic detachment. She's symptomatic, so buckle for me, and you can see this hole there, right? So I was saying to the resident who's a fellow now, let's do a circumferential buckle. It's easier, right? So what we decided is to do a buckle. Here is the video. And I really did not do Chandelier before, or actually I did some, but I did not like them. But then because he was going to do it, I thought we'd do it like a Chandelier. So this is the way I do it. It's a modified Chandelier. I just put a trocar, and then I look with the light in out. And the reason really I don't keep knocking off the Chandelier, which really annoys me a lot. So just I put the light in only when I need. But it's very important, as Tariq and Dr. Sharif and Hadi said, all the work is done preoperatively. So in the surgery, what I want to do is just do the steps, and that's it. There's no time for me to look and indent. This is all done before opening the eye. Because then the view may go bad. It may be like this case here, if you see what happened. As we were just setting up, we knocked off the epithelium, and we had to take it off. And that's really like just from the beginning. That's 2 minutes in the case. We knocked off the epithelium by mistake. So really, I want to do only the minimum, so everything is done preoperatively in terms of indentation and everything. And if the patient is not cooperative as a young patient, then once I put them to sleep, I indent, and then I open the eye. And here's the case here. We're starting. We know what we're dealing with, right? The tear is here. It's not showing very well in this view, but we saw it. But I'll show you in a different view. Then here, and actually the resident who's now the fellow did all the case. So you can see here, this is the Calasian curette, which is really very nice.
The same like me, huh?
Yes, absolutely. And then here we mark, and then that's what we knew. That's what Hadi told me. You hold it with the San Martin, and then you look. And then here, like, spot on. So then the resident said, we should put a radial. We're spot on. Everything is nice. So I said, yes, let's go for a radial, right? So what I do is I use the 5 millimeter. I multiply times 1.5. So that's a 7.5 millimeter. And that's how I do it. And we just straddle the hole. And here it was a small hole. So we thought one suture is very good, right? Here comes the cryo. And again, it's all done really by the resident. We're slightly a little bit off, but we thought we covered it nicely. And then here's the paracentesis after we place the buckle in the bed. And then I push for him, and then I hold the suture. These are 3 throws, so that would be tight, and then he tightened.
Ahmed, what suture are you
So
using?
there's
What
no
suture?
Ethibond in the US, so this is 5-0 nylon.
Okay.
But Ethibond is a nicer suture if you have it. And here, and then you look again for 2 things, the buccal-tear relationship and also for the patency of the artery. So that's important to look for that. And then after that, we cut off the remaining, and there's just one only suture, and then remove the trocar. It's best not to remanipulate the eye while removing the trocar because vitreous comes out, and then we cut the vitreous, and then we suture the port to avoid any infection, and then we suture the conjunctiva, and that's how. And that's no drainage. In a way, she had some subretinal fluid for some time, so I regret not draining this case. But we have an excellent buccal-tear relationship. That's one case. So I'm open to all your questions. I have a second case. So I just try to keep things easy. So I have like a rule. I multiply the buccal by 1.5. So it's just making it easy.
Ahmed, if you're putting a circumferential buccal, not a radial, then how far back do you go with your suture?
Yeah, that's a good point. That's the other case. Sorry, I'll just get the view. So this is here a second case where this is actually an interesting case. So the patient came, the patient came to us because of detachment after laser. So she had laser elsewhere and she had a MAC-on detachment, most likely coming from the edge of the laser. We don't know if when she had laser, she did have a tear with detachment or was just a rounded hole that was just laser, right? But anyway, what's appearing here in the picture, as you can all see, there's a detachment coming from the edge of the laser. We indented her, we could not find the tear. But it's most likely coming from there, right? That's what we thought. Okay, so we decided a young patient, no PVD, do a buccal. And again, same resident, same me as well. Sorry, I don't know why it's not playing. Okay, let me just play it from. Okay, I'm sorry. It's playing from here. Is it showing?
Yeah.
It's
Yeah.
showing.
Okay.
Yeah, we can see enough.
Okay. All right. So this is just a focus here on the area here. So again, same thing. Grease. So we put a trocar. Again, I think it's less exposure. It's nice that you don't really keep knocking off the chandelier and you use it when you need. And then we indented again here, and what you can see is the hole with the laser, but that's that treated hole. And then the detachment is starting from the edge of the laser here. So it's actually not the hole, it's just something happened at the edge of the laser. That's my view. It's probably a laser necrosis. So really, that's what I do in anterior detachment. So always the sutures are at the insertion of the muscle, the anterior suture. And then I multiply by 1.5 and I go back. Maybe in this case, I should have gone back a little bit more, but that's what I usually do with circumferential. I do it radial, but I think the more appropriate is to do it like what Tarek showed, because the scleral fiber is there. But I did it here radial with just one suture. Here, and then back, and then the buccal here, the 510. And then same thing you've seen before. So again, paracentesis.
Ahmed, what's the rationale for placing your soft silicone buccal flat down or round edge on the sclera?
I really don't know. I've asked Tarek this question several times, and every time he gives me the opposite answer. So one time he says this side, and then when I ask him again, he says the other side. So I don't know, Tarek.
I think it has to do with
you're muted.
I think it has to do with how the size of the buccal, the size of the indent afterwards. I think it does make a difference with the size of the indent afterwards.
Tarek, I don't know. I honestly don't know. I thought about it. I don't know.
I can't remember that I give you an answer. Even.
Right. I think once you said do it this way, and then when I asked you a few days after, you said do it the other way. So, right. So here, again, same thing, drainage, I press like crazy, and then he's tying, and the tip is to really hold nearer. With best actually if you have 2 needle holders. But then here, and then again really tight, and then we roll it back. And here, beautiful indentry. What else you want, right? So then the question is, did we forget to do the cryo? That's actually a good point. We did not, but we thought, okay, what were we gonna cryo? Are we gonna cryo the edge and then tidy up and then close? But I think this is a crucial point here, and this is the patient before.
You didn't cryo the brick, Dr. Ahmed?
No, I did not actually. I'm just trying to find the post-op picture. I'll find them. So I did not cryo the brick because a good point here. I'm sorry, it's playing a bit weird. Just 1 second. Yeah, it's not showing the post-op picture, but I'll get it as Ahmed maybe show his case. But I just want to show you something. So very important really to understand one thing. When you want the next day after surgery or the next few days, what you really want is a good buccal-tear relationship. It's not important to have a cryo reaction, because even if you do good cryo and you don't buckle well, it's not going to flatten, right? But what we really want once the retina is flattened, the buccal-tear relationship is not important. What's now important is a cryo reaction or a laser reaction, because then if the buccal sutures become loose, then the retina would not detach, right? So some people say, actually don't do any cryo, just buckle, retina flat, come after a month and laser. And that's what I did here. I thought, okay, we don't know really where the is, just buckle, retina flat, and then come 1 month after and laser. And that actually makes surgery easier because you don't need to do cryo. If the cryo machine doesn't work, that's fine, right? So I think that concept is really when do you want the buccal-tear relationship, when do you want the cryo reaction?
But this means that we need to drain.
No, because once you put the cryo only creates a permanent scar, but it's not going to work unless the buccal has a good relationship with the retina. So we did not drain. We closed the break. This is an acute detachment.
And did you do laser? Did you do laser post-op?
Next day, the retina was flat. Next day.
And did you do laser?
I did a laser a month after. Because in my mind, I just want before we discharge this patient, I just want the retina a good cryo reaction in case the buccal goes away. But I think it's a crucial concept that you understand why we're doing the buccal, why we're doing the cryo. Actually, even the cryo doesn't work, it doesn't matter. I think that's a crucial point, again, and for discussion, for all your opinion, really.
So if you close the tear, so the thing is the subretinal fluid is there because the flow of fluid through the tear to the subretinal fluid is more than the RPE pump. So if you close the tear or even approximate the RPE to the sensory retina, the RPE will pump the fluid out and the retina will go flat, right? Even without
yes.
cryo. So that's the main thing.
Dr. Ahmed, I have comment here.
Please.
Actually, we have two different things. The cryo reaction or the cryo, this is to make a chorioretinal scar around the break. Okay? This is has no role with absorption of subretinal fluid or resolution of retinal detachment. This is a function of the scleral buckle, as Dr. mentioned. And the rationale for scleral buckling, especially in non-drainage procedure, is that the placement of the scleral buckle changes the direction of flow of the circulation of subretinal fluid between the vitreous cavity and subretinal space. Also, the choroidal absorption rate inversely proportional to the cube of the distance between the retinal epithelium and the retinal and the retina. This means that if you approximated the retina to the retinal epithelium by half the distance from the detached position, you have choroidal absorption rate of multiplied by 2. This means the choroidal absorption rate will increase by 8 times. And if you decrease this distance by 1/3, you have 27 times choroidal absorption rate. So absorption of subretinal fluid, if you did non-drainage procedure, is a function of the scleral buckle. But creation of scar around the retinal break is a function of the laser or the cryopexy.
Yes.
The difficulty in the thermal buckle in the last case you did is a little bit difficult surrounding it with laser post-operatively, because you cannot. Sometimes it's difficult to make laser anterior to the break in presence of scleral buckle.
I don't actually, to be honest, I've done this a lot for several reasons. Most important is before the Chandelier, and then I cannot really see if the resident is doing good cryo or not. So we've done this a lot, and actually because of the way the sclera becomes indented, it's even easier to do it with the slit lamp. Even you don't need an indirect ophthalmoscope. I find it very easy. And as Ahmed, I'll get Ahmed to show his cases for the sake of time, and I'll find you the picture and show you the pictures afterwards. But
I just want to Dr. Sharif to repeat the formula, the cube of the what now?
The choroidal absorption rate is inversely proportional to the distance between the retinal pigment epithelium and the retina.
Which makes sense, right? If it's closer, it will.
So if the scleral buckle makes the retina closer to the retina, make the retinal pigment epithelium closer to the retina by half the distance, this means the choroidal absorption rate will be increased by 8 times.
Okay.
Yes.
Because you multiply. Yeah, that's the power.
This is a very old formula. This is a very old formula. Yes, the cube. Yes, cube. Okay. Yeah. This means that if you make it 1/2, this choroidal absorption rate will be 8 times, increased by 8 times. If you decrease it to 1/3, it will increase by 27 times.
I think what Dr. Sharif is meaning as well, you don't have to really close, but you need to have a good buccal-tear relationship, right? Yes. Okay. So I think
also the importance of cryo or laser is because all localized buccal tend to lose effect with time.
Yes, no, I agree.
Yes, of course, yes.
And that's the importance of the retinopexy.
Yeah, and this actually was a concept introduced by, I don't know how to pronounce the name, Dr. Van Muur from Netherlands. I don't know how to pronounce it. Is it Van Muur?
Van Muurs, yes.
Van Muurs, yeah. So he's a great surgeon in Netherlands, and that's what he called it, no cryo, no cry. Because then you don't see really what the resident is doing. You also have inflammation. I'm not saying do this in every case, but I'm just giving you options. Cryo is a very temperamental machine, as they say in England, right? It works one time and it doesn't work all the time. So also, it's just like, and also it's the concept, to be honest. So you have, Ahmed, if you can, I'm getting your presentation if you want to get it to work. We have a question. We have a point here from Dr. Ashraf Mahrousi as just putting the cryo, even if it does not close the break fully, it alters the current. And as Dr. Sharif kindly said, and is the painful laser? I'm not sure it's painful. I mean, we laser the patients here. It's inconvenient. It's good to finish it with a cryo, but we're talking about a concept and also other ways for doing things in case the cryo doesn't work or you don't have cryo. Ahmed, please go ahead.
So these are cases that in each one I thought of a possibility of buckle, and the decision was different in each one. That's a 31-year-old.
Can you play the video? Can you make it large?
The video is just.
Okay, can you make it large?
Okay.
Yeah. Yes.
So this was a 31-year-old female having a detachment, a fresh detachment of 3 to 4 days. I thought of a buckle in this case, but I thought that this break was larger than I could manage, and the rolled edge would be a difficulty also. So I'm sorry?
Does she have a PVD?
I didn't think so, no.
Okay.
But it I actually did a vitrectomy, and I did a PVD during the vitrectomy, and it went well, alhamdulillah. But do you think that you could buckle this one?
Well, my feeling, that's an ugly looking tear. So the
Yes.
problem here is the
It's
vitreous,
large.
and it's a large tear. Yeah.
Yeah.
So I quite agree. I will do a vitrectomy on that eye.
So your reasons would be because the vitreous, and it wasn't that good of a vitreous, right? She was high myope, -11, and actually she's seeing with this eye better now, but better than the other eye. But your reason for not doing buckle is because you think the vitreous is bad, or the tear is large.
Right, so the tear is large because of aggressive vitreous or aggressive vitro-retinal relationship. That's why it has that one. And I feel that the vitreous in these cases is pathological and should be removed.
I mean, here you've got a break that also has rolled edges. It's
Yes.
actually the posterior edge of the break is actually quite posterior. It's not that anterior.
Yes.
It's certainly tempting to do a vitrectomy, not a buckle, on a case like this. I'd be interested to know what Dr. De Boer says. But it's a big break to buckle. You need a pretty big buckle to support that
Yes.
kind of break. And you need to go pretty far back. You need to be sure that the whole break is well supported. Even if there is no PVD, my hunch would be that I would probably want to do a vitrectomy on an eye like this. Be it that it might fail and I might have to go a second time around.
I think Dr. Sharif will get this on a 4mm buckle. Right?
No, I think this is a large break, maybe more than 1.5 hours or 2 hours.
Yes,
the problem
actually,
here is
she feels the field
2
effect
hours.
right now. With this with this break, she feels the field effect actually.
Because yes, I
Right.
I would go for vitrectomy from the start, because this if I do buckle this break, you have starting BVR, and to make cryo to the very big break, you would do many
A lot of
cryo applications,
A lot of cryo.
which will induce more BVR, and so I would go for buckle from the start. Actually,
Ahmed, how old was the
for
patient?
vitrectomy, sorry.
31.
31. Yeah. For me, this is like nearly a giant break in a young patient.
Yeah.
The rolled edges. So I would, it's a difficult case. I'm sure you did. It was difficult inducing PVD because in detached retina, I would try to induce the PVD on the side of the attached retina, then get it forward. But I will do. I will definitely do vitrectomy. Actually, I may leave the PFCL and come back. I would treat it like a giant break.
Ahmed, did you put gas? Did you put oil?
I would put either gas or PFC. Sorry.
Ahmed Habib.
Dr. Habib,
Yeah.
Yes. Okay.
what did you do?
I put oil actually.
Put oil.
Because
Okay.
with the myopes, they tend to be happier with oil for the while that the oil is there, and then I would do second oil removal with fake one, give her a chance for better vision.
And when you induced the PVD, what did the break change size? Did it affect the break configuration, or did it not affect the break?
No, just had to trim the rolled edge right here. I usually try to flatten the rolled edge, but at this time I couldn't. And the only problem now that she feels the field effect of the large break.
What do you want?
Any other breaks peripherally, or is that the only break?
No, that's the only one.
Hedy, would you put gas or oil in this patient?
I have to say I'd probably oil a eye like this. I would probably oil her as well.
And Tariq? Gas or oil?
I just don't like this. I mean, as you said, Ahmed, this looks like a small giant tear.
Yeah.
Small joint tear.
without a PVD. Without a PVD, of course.
Yeah.
It's all,
Like this expression, small giant tear.
Yes. Tariq, what do you do for the small giant tear? Gas or oil?
So Ahmed said that the patient is happy, so I will go with what he said. I will put oil.
You put oil.
She's happy for now.
The worry I think with these eyes is so you sometimes can start to see the retina unzip, so you start to see breaks coming off at in other parts of the retina in that same kind of location in other areas. So this is kind of why I'd be thinking of oil as well.
Yes.
I'll put the PFCL or gas. I'll leave the PFCL for 2 weeks, like
So
giant breaks, or do gas if the retina doesn't slip.
If you put PFCL, use Decalin or Octane. If you leave it in,
PFO, the one we use, PFO.
you don't know.
No, Decalin or
Peripheral Octane. Peripheral
Octane.
Yeah.
Okay.
What's your experience for this type of detachment when using C3F8?
Yeah, that's what I do. CS3F8 or PFCL.
But you didn't remove the vitreous completely in this case. So the patient didn't have a PVD. The patient is phakic, is quite young. There are still some vitreous attached, so you didn't do a full vitrectomy. I mean, that's what I... And leaving a gas inside the eye may cause a PVR retinal detachment. So you need to stabilize the retina for some time, for a good maybe 3-4 months, and then take the oil later. That's what I would do.
Okay. I would actually do. I usually do in these cases good shaving with oil. I don't like to take chances with the small breaks that could have happened with the close shave. So I put Sigma oil for just 2 months, 2.5 months, and take it out.
So would you be able to do a good shaving in the presence of lens in phakic eye?
I don't think that's a problem. I have good indentors. the nurse is a good indentor.
Ahmed, for the sake of time, do you want to move to the next case?
Okay.
Yeah.
So that's a second case. That's an older detachment. She had this detachment for a month. As you can see, some minor PVR and also a small break, but posterior. I would think that I would put a radial sponge in this case, but I didn't have the sponge. It wasn't available, so I took a chance and I did vitrectomy with gas, and it went okay. But
what is the break exactly?
Temporal.
Your temporal, right?
This one, but this area was also not.
Where?
Here.
Is the nasal retina? Yes. Here.
Yes, nasal retina. Can you see my mouse?
No.
Okay. Can you see it now?
Yes.
Here, but this area also wasn't that nice, and there was an iatrogenic break that happened during the vitrectomy here. But I still put SF6 and it went okay.
Ahmed, how old?
She was 27.
And no PVD as well, right?
No.
I think it's very difficult to buckle in this area, and I think would be difficult.
That's why I was asking, what's the vitrectomy threshold for the posterior break? How posterior would the break can be to do buckle to do vitrectomy, not buckle?
I think it depends on how comfortable you are to put a big buckle posteriorly and how easy in your hands it is.
I'm not comfortable with the buckle. Period.
Yes, I think in this is a lower nasal break. I will adopt the same technique Dr. Tari mentioned before. I will open the two muscles, open the conjunctiva, and look, is it reachable by the scleral buckle or not? If it is, I will do radial buckle for the break. I think it is not too posterior for scleral buckling. But actually, I will try
to do vitrectomy and guess.
If it is not reached by buckle, okay, I will do vitrectomy.
That's a good idea. So what Tari and Dr. Sharif said. Hani, what would you do?
Yes.
If there is a PVD, the answer is simple. I'll do vitrectomy. if there is no PVD, I'd probably try and buckle it if I can reach that far back. But it looks a bit more posterior than I like it to be for a buckle.
Yeah.
So my hunch is that I would be going for a vitrectomy.
So Dr. Ashraf Mahrouz is one of the audience here. He's a retinal surgeon. He's saying it looks too posterior for him to buckle. Yeah, right. Nice case.
Thank you. So
Buckle.
this one. So this one, she's 11 years old, and she had hypotony, and you can. I'm not sure if you can see the choroidal detachments.
Choroidals, yes.
Yes. So I tried giving her steroids for 2 weeks. For 2 weeks, and she didn't improve. Actually, I did vitrectomy for her, and I just removed the silicone, and she's 0.2 vision now. But does some is there a possibility that for the sake of a buckle, you would inject some BSS to try to do a buckle in this case?
This has giant break or what? Where is the break?
The break is peripheral cheek. It wasn't a giant break. It was a small, a smaller dialysis, but with time, after these 2 weeks, the dialysis became larger, sort of a giant break, right? But after the 2 weeks, I saw her with a smaller break, and the break increased with time. So I regretted waiting for the.
Yes, I think 2 weeks is long to wait for such a detachment.
I thought I would give her the chance that she's 11.
Yes, but also choroidal detachment is not a contraindication for scleral buckle. So if you have,
what would you do?
If you have a small retina, I would give steroid for 2 or 3 days, and I do scleral buckle for the peripheral break.
Even with this kind of choroidal detachment?
Yes, choroidal detachment, once the retina is attached, it will resolve with systemic steroids. Also, choroidal detachment will offer you advantage. You don't need to drain, as you have good tear relationship, good tear-buckle relationship. You may inject air inside the eye, beside scleral buckling, beside buckle, and in a few days, the choroidal detachment will go away after the retina is attached.
So your plan would be give 3 days.
Scleral buckling 2 days, and scleral buckling immediately.
Inject BSS to
inject
the eye during the operation.
Air, not BSS.
Air during the operation.
You prefer BSS, yes, during the operation.
So what would the rest of the panels do?
The rest, what? Okay.
Dr. Tari, Dr. Hadi, Dr. Salem, what would you do?
Right. So what I will do is, in these cases, in my hands, on my own experience, steroid doesn't work in choroidal. You need to put the pressure up. So I will take this patient. I will arrange a surgery. I will put a buckle if I can see the dialysis, and I will put a longer acting gas, maybe 0.500% C3F8 to maintain the pressure for some time till the choroidal settle down. And I think if I put the pressure up, the choroidal will disappear. Sometimes the choroidal buckle the tear. So if the choroidal is in the right place, it can buckle the break. That's what I would do.
Yes, this is very interesting. I have seen maybe 3 or 4 cases of spontaneous resolution of retinal detachment after choroidal detachment occurred.
Yeah.
But given that the vitreous contracted after a while and increased the size of the break, wouldn't it be the buckle to be an overkill? If you enter and actually treat the vitreous that is causing the problem, wouldn't be this the logical step.
So at the beginning, I didn't know if the vitreous is going to behave that way or not. But definitely, if it behaved that way, and I need to do a vitrectomy, I'll go ahead and do the vitrectomy. But
After the buckle.
at the beginning, yeah. I mean, if it didn't work, I will go ahead and do a vitrectomy.
So
Again,
Tarek, let's just get this right. So you would do a vitrectomy and you would oil the eye, or would you do a vitrectomy plus buckle?
No. At the beginning, because of the dialysis, at the beginning, I will put a buckle and put a long-acting gas. So the eye is C3F8. Normally, I will put 0.3, but in this case, I will put like 0.5. So I can maintain the pressure for some time. The reason for the choroidal is the hypotony. So that's what I would do. If it progresses, if the vitreous carry on contracting and cause a giant tear, I will go ahead and do a vitrectomy.
And Ahmed made it contracted because it was not treated, but if it gets supported, it may not contract because you're relaxing the retina. I like what Dr. Sharif said, treat the detachment of today, not of the future. I really like it. Yeah. For me, I would do a buckle, even if I cannot find a break. That's for me an indication of encirclement. I rarely encircle, but if I cannot find a break, and we dealt with cases like this, similar, but not with choroid, like a detachment in kids with PVR, and a total detachment, we cannot find a break. So what we did is we encircled, we drained, and then we put gas. And then later on, the retina was flat, and we just lasered over the break. So that's for me maybe an indication of encirclement if I cannot see the break. If I can see the break, then I would do like Tarek. Then if the patient detaches, I would do vitrectomy. That's what I would do.
Okay. Dr. Hadi, what do you do?
Yeah, I would refer her to my pediatric vitreoretinal colleague.
So if he's on holiday,
that's how things work. Or like book her for surgery and don't come the next day, right? Ahmed, do you have any other cases?
Yes, this is the last one. This is the usual. My usual indication for buckles. So he was coming for LASIK, and there was a lower detachment, inferior detachment, and the macula was partially off. He was seeing 0.4, and the macula was off more than the line that was that you can see here. So I did this was actually 180 degrees. So I did an encircling band with a tire about 170 degrees, and it went okay, alhamdulillah. But do you think that you could put just a tire, not an encircling band?
Where's the break, Ahmed?
Actually, when I indented, it was very anterior. It was in front of the insertion of the medial rectus. So I couldn't put the buckle on it because it was towards the anterior to the insertion of the rectus muscle. So I did an inserting band, and it went okay. Yeah.
I would put a small circumferential under the medial rectus with a suture on each side. That's what I would.
But it was the break was anterior to the insertion of the muscle, not posterior to it.
But probably, I think you still can get a break, a muscle there. It's probably. I think it's anterior, but I think you still can get a small circumferential, 5'10" or 4 millimeter
in front of the muscle. You can do that.
It's like anterior, but not really in front. It's like in front.
Yes, in front. I'm sure.
I don't know. I've never met this situation.
But the retina stops before, Ahmed.
Yeah, that's the thing.
We did that. We did the indentation. We did actually it wasn't.
There is no retina in front.
Was.
I think can you put the buckle on top of the muscle? I really don't know, Ahmed. I've never met this situation before.
No, I just Ahmed, if you put as Dr. Ahmed Salam said, very small even soft silicone, or even tire with one suture on each side of the medial rectus muscle. The first, the anterior suture line would be just the muscle insertion. You see?
Yeah.
So you will support the vitreous base in this area, including that anterior break. One stitch on either side.
It was supported
Sorry?
with the tire and the encirclement. It was.
I mean, you managed to get the encirclement,
So
right?
if your encircling band supports the break, then your segmental will support the break as well.
Yeah.
In principle, as long as you're all the way up to the aura, so break to aura occlusion, then whether it's an encircling band or a segmental, it will be up. It will be support the break. So it will support the break.
You mean the segmental? The just a tire would be enough, right?
Correct. Well, segmental
Yes.
tire, yeah. Segmental, yes.
Okay.
Okay, before we just move with Mohammed with the case of PDR and we move the discussion, this is the case of the patient. I showed you, and I found the pictures here.
Yes, very nice.
Very nice. Very nice.
Next day.
This is post-operative.
This is post-operative next day, and this is 1 month afterwards. And you see how we did the laser? We just covered more of the temporal side, and this is done on the slit lamp.
Very elegant.
Yeah, 1 month. That's 1 month afterwards. Yeah.
Very nice.
So I think it's just it's another way of doing things, and again, the concept behind it. Okay, we'll move the discussion now to Mohammed, and a very nice case of PVR. But before that, Mohammed, you had a question, right? What's the role of buccal in PVR? Correct?
PDR.
So how can we?
I have two cases.
Okay, is this your case?
This is a case of, no. This is a case of pediatric retinal detachment. 6 years old boy have a chronic lower detachment, as you can see, and lower break, small lower break at 6 o'clock. Okay.
So lower break. Mohammed, can you move the sign there? You have. Can you? Yes. Okay.
And this is the presentation of the patient with macula of RRD, chronic, and he did a buccal. After 1 month of the buccal, the retina is flat, the macula is on, the patient have a vision of 0.2. 2 months later, recurrent detachment. Okay.
What buccal was done? Like encirclement?
No, segmental.
Okay.
And I will go for vitrectomy.
So how old is the patient?
6 years old.
6-year-old.
Yeah.
And Mohammed, why did the case detach? Are there open breaks?
Yes. Redetach. Yes, it will open break. The retina is
open breaks posterior to the buccal or over the buccal, and there's a problem?
over the buccal.
But
I think the retina was shortening, and as you can see here.
Yes, I think this is a buccal failure. This is a break, yes?
Yes.
Yeah.
Question for you, Dr. Sharif. Can your buccal be failure after 2 months of successful buccal?
Yes. Yes, it is early buccal failure and late buccal failure. Just in this patient, the break is not supported by the buccal posteriorly as well. As you see, this is segmental buccal or encirclement?
No,
is it encirclement, Mohammed, or just segmental?
Segmental.
Yes, as mentioned before, usually segmental buccal tend to migrate anteriorly. So if the patient no enough cryopexy, or the buccal effect decreases with time, so this with anterior migration of the buccal, the break is no longer supported posteriorly, and this is the reason for redetachment. And in this patient, you can in this particular patient, if that the single break is present, I can as long as this is young child with no BVD, I can reopen and position the buccal more posteriorly and make more posterior sutures, and that is and drain again.
But there is obvious,
in cryo,
obviously,
like a scale back from the start. Sorry.
but there is shortening. There is obvious shortening in this retina. I'm not. I can't imagine how a buckle could negate the shortening effect of the retina. If there is an education, how the buckle can negate or nullify the effect of the shortening of the retina. If you indent the wall of the retina, the wall of the eye, the retina would have to also bend with the wall at the same for the same surface area. So how can a buckle decrease this surface area? It doesn't decrease it, and the retina would have to flatten over the whole area also, right?
No, Ahmed. The buckle indents the globe, and this decreases the surface area of the sclera. Indents the globe over the sclera.
How can indent? If you indent the wall, it would be it will be a curve, just a curve.
So,
but the surface area would be the same.
What makes the retinal short?
Internal fibrosis.
Yes, it's vitreotraction and fibrosis.
Yes.
The buckle alters the direction of vitreotraction, like the gloves you wear with flexible hands.
But the retina is still short. I am with the buckle can decrease the effect of vitreotraction. Okay, I am with that. But if there is a retinal shortening, there is the surface area of the retina is decreased. And if you do a buckle, you would have to you are asking the retina also to be flat over the whole surface area, which is not changed. The surface area of the wall is not changed.
It's a matter of a new aura serrata or a new vitreous space. Yeah, this is a new vitreous space. You make a new vitreous space.
If you do a new vitreous space, you would have to detach the retina from its insertion to another insertion.
I think if you encircle an eye,
yes,
and then you will, by definition, reduce the radius of that very anterior circle, yeah?
Yes, that's exactly what I mean.
Therefore, by definition, you are going to reduce the surface area because that circle will actually become smaller. It will have a smaller radius. Okay.
So the effect that would happen, that the vitreous, the shortened vitreous would not have the same effect, but the surface area that the retina would have to flatten over is the same.
Ahmed, it's not, because if you think of big tears, when you buckle them, they become redundant, right? And that's like the mechanism of fish mouthing.
You're saying
the retina becomes redundant.
You're saying it's a tear.
No, it's the retina in general.
A tear that I can understand, because the retina is plucked off its insertion and it is inserted in another place. But if it is not, if there is no tear or a very small tear, and the retina is shortened, it would be tense. If you put the buckle, yes, that it can be flat on the anterior part, but the posterior part would have to flatten with a curve to cover the surface area.
Yeah, I think it's a good point. I mean, there's a nice drawing for what Dr. Sharif is saying in the book by Reynolds Michael, how the direction changed. I think it's a debatable point. I think we need to move on.
I think the main thing is that you are going to reduce the tractional forces on the retina more than anything else. So you're going to alter the traction on the surface.
Yeah. So question for the panel, again, the same question Mohammed asked with you. So Dr. Sharif said he's going to revise the buckle. It's a buckle failure. and if he can buckle or move the buckle backward, that's what he will do despite all the PVR and subretinal pains. I will do exactly the same. Tariq, would you do something different?
No, I will do exactly the same.
And Hadi, would you do something different?
How old is the patient again?
6.
6 years.
6. Yes, I mean, I don't like revising buckles as a rule.
Hadi will send it to the pediatric.
It's not easy revising buckles in general. So unless you do this all the time, it's not an easy job, I think. And in general, and I don't do pediatrics, but in general, in my hands, if a buckle fails, let them do vitrectomy afterwards.
Right. So can we move on to the next case, Muhammad, for the sake of time? My indication for vitrectomy is really if there's significant PVR and the break look buckle, but it's really open. You know that like there's something else needs to be done from inside. But if the break is not supported, I will move the buckle. Muhammad, do you want to show your next case? It's here. Okay.
Yes.
We got nice drawing here. Can you make it bigger or? Yeah, here you go. So that's another 6-year-old boy.
This is a case for today clinic, my today clinic, just 1 hour before our show. This is another 6-year-old boy, history of trauma 3 months ago, and he reported that the trauma is from a wire. And so this total retinal detachment with a Strafford here, lower retinal detachment plus some sort of shortening. I examined the temporal area. I found this a large slit tear was underneath a wire. And on examination, I found the side of entry of this foreign body here. My questions is, what will do for this boy tomorrow? This surgery will be tomorrow.
Maybe can we start with with Ahmed?
By the way, my friend Ahmed Habib will be with me tomorrow in this surgery.
Okay, so Ahmed, what are you gonna do? Ahmed Habib, what are you gonna do? Start with you.
I don't know about this surgery. No question.
So I think there's the foreign body. How you're gonna pull it? Are you gonna do vitrectomy?
You cannot do vitrectomy because it can extract this foreign body from outside, from the scleral inlet, and you go through for a buckle.
Why buckle? There is obviously a star fold in the posterior fold.
So Dr. Sharif, what are you gonna do?
Actually, I will explore the sclera at this site. I open the conjunctiva and I isolate the lateral rectus, and if it is as seems to be wire, so it is uniform thickness also, I will draw it from the sclera from outside. And as I think this is a Stafford PVR, yes or no?
Yes.
Okay,
no
so I will go.
No subretinal PVR. I will suture the sclera and go for vitrectomy, and we'll do retinectomy around the entry site of the foreign body, and deal with you will not.
Yes, around the incarnation site.
You will not put a bucket.
I think no place for bucket because you will remove the retina from inside around the incarceration.
Okay.
And do laser after that.
And oil, right? And oil.
Sorry?
And oil.
Yes.
Hadi, would you do anything different?
No, I mean, I quite agree. I mean, I think you need to explore this area temporarily, take the wire out of the outside, most certainly do a vitrectomy because of this star fold, try and peel that if I can. And I would certainly oil this eye, yeah.
And would you do a retinectomy around the incarceration as well?
You need to clean that break basically because there's clearly a break from the incarceration site and from the wire. So you need to clean the break. So it's a very small local adjustment of the break just so you can laser that neatly. Yeah.
And Tariq, will you do anything different?
No, I will do exactly the same. I'll do retinectomy. If I can do choroidectomy as well as suggested by Frank Kuhn, I will do it laser around there and then I'll try to flatten the retina.
There is a rule of aggressive ILM peeling or what you are called wide area of ILM peeling in this case.
Yes,
I don't
ILM.
remove ILM in PVR cases. So if I don't see much epiretinal membrane, but I can, maybe the one nasal is subretinal, I'll try to do a small retinectomy, try to remove if these are subretinal. If the retina go flat, that's fine. If not, I will need to do a retinectomy and endolaser as Ahmed showed the last case.
Do you
But do you feel that there is a role for the choroidectomy and the retinectomy? I think I would remove the wire and just laser this area.
Tarek, how would you do a choroidectomy? What would you actually physically do?
So you need to put the diathermy up to 25 or 30, and then surround that area with diathermy, and go with the cutter and try to remove the choroid. I've done it once after speaking to Frank Kuhn, and it wasn't easy, but I managed to do it at the end. And what he's claiming is that all the PVR occur around that area of injury.
So you will excise choroid at the site of the incarceration temporally, is that right?
Exactly.
Through the break.
Is there an incarceration?
So the white area should be an incarceration, the white area temporally.
So choroidectomy was introduced by Dr. Ferenc Kuhn and the
what's the
PDR,
difference?
but then the problem is bleeding, so just be wary of the bleeding. Even sometimes
So this
diathermy
is my question. Is this a incidence of bleeding when I remove this wire from outside? It's different if I remove it from inside.
I think the easiest would be outside, really. And I would do the same as Dr. Sharif and Tare. And I think it needs a retinectomy around it. I wouldn't do choroidectomy. I tried it several times. They get bleeding, and diathermy can't stop the bleeding in my hands.
Okay.
So good luck. So have a good picture.
حاجز يا ابني ما مكان انا اروح
أنا بعد حالة after the ROP cases of Ahmed Habib tomorrow, I will join after him.
So that's like Ahmed Habib suicide tomorrow. ROP.
One case of ROP and then this case after that.
Right. It's
So
very.
we have a question.
Can we have a final comment? We have a final question from Dr. Ashraf Mahrous. Sorry, of Dr. Mohammed Hassanein. If you're doing a buckle and you want to put air to just manage the hypotony, or there's a fish mouthing, would you use air or SF6 or C3F8? I think most would use air or SF6, right?
Yeah.
Short acting.
Areas.
Yes.
Air.
Okay.
There's a question from Dr. Muhammad Harman. If you have submacular bleeding after drainage?
Yes, that's a good.
This is a very good question. Actually, if you have bleeding, I usually tell the patient to make the nasal side dependent, the nasal retina dependent, and I try not to complete the drainage subretinal fluid, to make some residual subretinal fluid, and ask the patient immediately after awakening to adopt a face down position. And this, in most cases, usually the blood is milked away from the macula, and that is important.
So,
Any subretinal blood.
So Chief say again. So what you do is you ask them, you try to position them away from the macula, right?
Yes, I make the nasal retina dependent. So
Right.
if I'm operating on the right eye, I tilt the head of the patient to the left side.
Right.
Then after finishing, I ask the patient to make face down position. So any blood will milk it away from the macular area.
But how you,
And,
you put air as well to help milking?
Yes,
away?
but yes, it's essential. I put air immediately.
And now I do the same, but I also put TPA in the vitreous because the
TPA.
blood. So I do exactly the same, but I put TPA in the vitreous because the blood.
But this may induce vitreous hemorrhage.
Yes, it
May
does.
make-
Yes, but I tried 2 cases where actually I opened and I converted and I took the blood out, but it's very difficult, and we need to do a big retinectomy because the blood clots. And that's why I stopped doing this. And in the case where it happened again, I put TPA, positioning, and air. And the best way is to avoid this by trying to avoid drainage, I think. The one with the intraocular foreign body, I think Dr. Hassani is asking about tamponade. I think we're all agreeing on oil, right?
Yes.
Yes,
Yeah.
right.
I mean, even PFCL here is not good because there's PVR. You cannot leave the PFCL for long. And this is a case where there's extensive PVR and retinectomy, so be oil. Right. Any other points of wisdom? I mean, interestingly, the discussion went so quickly, and it's now like past 2 hours. So it's very interesting. I'm sure we've learned a
It
lot.
was nice. Yes.
Any final point of wisdom from Dr. Sharif Dabur other than buckle everything with 4 millimeter buckle? Any final comments, Dr. Hadi?
Thank you.
I mean, this was a very interesting discussion, very useful points, very useful learning points from the whole panel. I've learned a lot.
Thank you, Dr. Hadi.
Tariq, do you have any?
No, thank you. It was
Ahmed,
really very
do you have anything else other than if the retina is going to relax or not? I think that's we can remain here.
I'll have to draw it for you.
Yeah, I think we remain here to the morning.
And then post the break with
That's what we need to.
which is anterior to the.
And Mohammed, good luck with the case tomorrow. Any final comments?
No, just a break for me and just break.
Yes, we will think of you. All right. Well, thank you so much. Well, a final word.
Thank you, guys.
Thank you, Ahmed.
Select the cases when you're doing buckle for the beginning. Really select the cases. I think that's very important. And then hopefully it becomes easier. And thank you so much all for joining us. Thank you.
Thank you.